All right, welcome everybody to Cardiovascular Medicine Grand Rounds. I'm very excited for today's presentation and speaker. Dr. Sara Saberi is an associate clinical professor in the Division of Cardiovascular Medicine at Michigan Medicine, and she's also the co-director of the Inherited Cardiomyopathy program at the University of Michigan. She received her bachelor's degree from Northwestern University in Evanston, Illinois, and her medical degree from Wayne State University in Detroit, Michigan. She obtained her residency training in internal medicine and cardiovascular training at Michigan Medicine in the University of Michigan, after which she joined as faculty in 2010. Dr. Saberi's clinical work is focused on providing comprehensive care to patients with genetic cardiomyopathies and their families. Her research work aims to understand environmental factors that impact disease progression and onset in hypertrophic cardiomyopathy. She's also involved in clinical trials of new treatment options that can prevent or delay the onset of hypertrophic cardiomyopathy in this disease. I also have to add that she's a phenomenal coworker, friend, teacher, and mentor. So we're very excited for your talk.
Thank you, Dr. Molis, but I know you say that about everybody. I'm Sara Saberi, and I'm happy to come to you to give an update about kind of the management strides that we have made in hypertrophic cardiomyopathy. These are my disclosures. It looks long, but they're primarily related to my clinical trial involvement. So I'm site PI for several clinical trials, and steering committee members for a couple, and publication committee members. I have sat on advisory boards for Bristol Myers Squibb and Cytokinetics as well. So our objectives today are going to be to give and show the progress that we've made in our understanding of hypertrophic cardiomyopathy, look at ways in which we can target early disease initiating pathways. We're going to give an update about risk assessment for sudden death, and then the medical management of obstructive hypertrophic cardiomyopathy. So first, let's see where we've come to in the last kind of 10 years in terms of our understanding of hypertrophic cardiomyopathy. So HCM is really, by definition, unexplained thickening of the left ventricle. This is kind of what we see. There's a lot going on in HCM that our eyeballs don't see just by looking at images of a patient. The hypertrophy is in the absence of an external load. There should be lack of another disease process that could explain the same degree of hypertrophy. And most often there is increased LV systolic function, or at minimum preserved. And the diagnosis is really completely independent of whether or not there's outflow obstruction. So I'm showing you here three cardiac MRIs, three patients with hypertrophic cardiomyopathy in their cardiac MRIs. The one that's moving right now, the asymmetric septal, this is the classic reverse curve morphology where the septum really kind of looks like an almond. The left ventricle has become crescent shaped. There's another morphology called apical variant hypertrophic cardiomyopathy where the majority of the thickness is towards the tip of the heart. And then a morphology that we're more recently recognized in the last couple of decades, which is midventricular hypertrophy complicated by an apical aneurysm. I'm showing this in particular because it's a quite different morphology than apical variant hypertrophic cardiomyopathy and carries different risks than apical variant hypertrophic cardiomyopathy, all related to the aneurysm. So the aneurysm really puts people at risk for developing strokes and for sudden death. And we'll talk about those things later, where those particular complications tend to be a lower burden in patients with true apical variant hypertrophic cardiomyopathy. So HCM is the most common genetic heart muscle disorder, occurring in about 1 in 200 to 1 in 500 people worldwide. It's a genetic disease. And when we do genetic testing, we can often identify the sarcomere, the disease-causing sarcomere variant in about 60% of our patients. And the most common occur in the myosin-binding protein C and in the myosin heavy chain. When we look at families, we can identify patterns more often than not. So this is a pedigree of a patient of mine. The patient itself is identified with that black arrow. He's in his 40s and was diagnosed with hypertrophic cardiomyopathy when he was 30 years old. And if you look at the family, then he has a daughter who's 15, who has borderline wall thickness for her age, gender, and body size. So that's automatically in a 15-year-old kind of a little bit of a red flag. And his father died at age 42 of a stroke, which is, again, highly unusual and starts to kind of put up little red flags in your head that there's something going on. The disease is passed on in an autosomal dominant fashion. So each of my patient's children and siblings have a 50-50 chance of having inherited the same genetic variant that has caused disease in him. We have learned a lot through research in the last decade, and I'm proud to say that University of Michigan's Inherited Cardiomyopathy program was one of the founding members of the largest international clinical and genetics registry called the SHARE Registry, the Sarcomeric Human Cardiomyopathy Registry. We follow about 12,000 patients worldwide with hypertrophic cardiomyopathy, and sites in the United States include Ann Arbor in Michigan, Brigham, Penn, Boston Children's, Cincinnati Children's, Stanford, and Yale. We're a community of HCM genetics experts and really trying to understand the disease process as a whole better. Our database includes key clinical parameters, genetics data, and outcomes, and has this kind of rigorous data collection has allowed us to really learn a lot. So this is a busy looking slide, and I'm going to walk you through it. So this is the first output of our of the SHARE registry, really looking at what is the role that disease-causing variants play in terms of disease course and outcomes. The red line in each of these graphs is people who have had genetic testing and the testing did not show a sarcomere variant. The green line are people who have been found to have sarcomere, disease-causing sarcomere variants. And then the blue are those people who on genetic testing were found to have variants of uncertain significance, meaning we don't have enough information to say that they're benign. We don't have enough information to say that they're disease-causing, and they're somewhere in between. So what we really looked at were heart failure outcomes, ventricular arrhythmia outcomes, and kind of an overall composite outcome. This first graph here is the overall composite outcome, which is first occurrence of any malignant arrhythmias or arrhythmia-related events like aborted sudden death, and appropriate ICD therapies. Also included the heart failure composite, which is first occurrence of an ejection fraction, that should be less than 35%, advanced heart failure symptoms, New York Heart Association class 3 or 4, and a need for transplant or LVAD. So in that overall composite, we also included atrial fibrillation and stroke, as well as all-cause mortality and death. And you can see that those patients who have negative genetic testing fare better in the long haul in terms of those kinds of outcomes than those patients who have a sarcomere mutation. And then when we drill down into each of those, we find the same things. In that in this graph, I'm showing you the ventricular arrhythmias, and you can see that it's actually a very low event rate. But again, those who have pathogenic sarcomere variants have more events than those who don't. And the blue line, those variants of uncertain significance, live somewhere in between, meaning that for sure, some of those variants of uncertain significance are disease-causing. They correlate with bad outcomes that we anticipate with HCM. We just don't have enough information yet. Graph C is what's the proportion of patients that meet the heart failure outcomes, and the same pattern replicates, and the same thing with atrial fibrillation. So those patients that have a sarcomere variant fare worse in terms of developing atrial fibrillation. I would like to call your attention to the fact that when we look at the burden of ventricular arrhythmias as compared to the burden of atrial fibrillation, it's a really different graph. And the risk of ventricular arrhythmias is far, far lower than the risk of atrial fibrillation. And yet we pay an outsized proportion of attention to the risk of sudden death and ventricular arrhythmias than we do to atrial arrhythmias and to congestive heart failure, which also is a predominant finding in this population. Those who have sarcomere variants have a greater than twofold lifetime risk of death, heart failure, malignant arrhythmias, and atrial fibrillation, a 4.5-fold risk of requiring transplant or LVAD, and a 6-fold risk of developing LV systolic dysfunction as compared with those who do not have sarcomere mutations. And non-familial hypertrophic cardiomyopathy, meaning we did genetic testing, we can't find a pathogenic variant. We do a good 3-generation family history, and there's no family history of hypertrophic cardiomyopathy, but clinically, we see signs of hypertrophy. Those patients with non-familial hypertrophic cardiomyopathy actually have far less risk. Mortality and composite hazard ratio was about 0.5. What we've also learned is that age makes a difference. So these are those same 4 composites, the overall composite, ventricular arrhythmia composite, heart failure, and atrial fibrillation. And on the x-axis in each of these graphs is the age of the patient and when they were diagnosed. And what you can see from these graphs is that those who were diagnosed under the age of 40 in the lighter shades, as opposed to those who were diagnosed over the age of 60 in the darker shades, fare worse in terms of developing outcomes. So for example, by the age of 60, in terms of the overall composite, those patients who were diagnosed under the age of 40 have about a 75% risk of developing the overall composite, as opposed to those patients who were diagnosed at the age of 60 and where their risk is just 10 years later. Again, would like to draw your attention to the fact that those patients who are diagnosed younger have a far higher burden of heart failure as they get older than those who are diagnosed later, and the same for atrial fibrillation. And again, the ventricular arrhythmia composites, you can see that those patients who are diagnosed in their 60s just barely creep up above that 0 line in terms of arrhythmic events. When we compare the longevity, kind of mortality rate of patients with HCM to that of the general US population, it's still pretty low at younger ages. So the red bars are patients with HCM, the blue is the general US population. And while it's low for those aged 20 to 30, it's still, the mortality risk is 4 times higher than that of the general population. When you get up into your 50s, that mortality risk is about 3 times that of the general population. So there is a bit of a misnomer out in the literature that hypertrophic cardiomyopathy in today's day and age is really just a long-term disease like diabetes and hypertension that can be managed and we've turned things around, and that's really not the case. What we've also found is that sex matters. So in this study, we looked at 5,873 patients with hypertrophic cardiomyopathy that had enough clinical and outcomes data for us to be able to report on. And what you can actually see right up front is that only 38% of the participants were women, as opposed to 62% who are men. That automatically tells you something about the referral patterns to specialty centers with hypertrophic cardiomyopathy. We can see that women are older than men at the time of diagnosis. We can see that women tend to have a greater propensity of being found to have disease-causing sarcomere mutations in their genetic testing. They're more symptomatic, so they have more of them have New York Heart Association class 3 and 4 symptoms at the time of their presentation. They have more of a hypertrophy burden, and they have evidence of downstream consequences with bigger left atria. And that is despite the fact that the obstructive physiology isn't all that much different, though seems to be a little bit more. So women are seen at a later stage of their disease process in specialty HCM clinics than men are. When we looked at outcomes and the care for patients, once they have actually gotten delivered to an HCM center, we actually found that there's really no difference in terms of referral patterns for septal reduction therapy. So the patients get the same, essentially the same amount of advanced care. There is a little bit of an outsized proportion of women that get alcohol septal ablations as compared with men. The stroke risks for women are significantly higher than they are for men, even though there is really no difference in the burden of atrial fibrillation. I think, again, that probably speaks to the advanced stage of disease when they present. ICD implantation in women is really no different than men. When we look at outcomes, we actually see that women suffer much more significant heart failure than men do. There's really no difference in the risk of ventricular arrhythmias, but they have a higher mortality rate than men do. And whether or not this is a reflection of the interplay of sex and the disease, sex hormones and the disease, or the kinds of care that women are getting versus not, still really needs to be determined. I wanted to just take a moment, since we talked about atrial fibrillation a little bit, just to hammer in that the CHA2DS2-VASc score does not apply to patients with hypertrophic cardiomyopathy. It does not correlate with their risk of stroke. Atrial fibrillation affects about a quarter of patients with hypertrophic cardiomyopathy, 4 to 6 times higher prevalence than the general population. Where the annual stroke risk in the general population is about 2%, with HCM, it's more like 10 to 12%. So a diagnosis of hypertrophic cardiomyopathy is an automatic indication for anticoagulation when atrial fibrillation is picked up. You should not bother with the CHA2DS2-VASc score. It will fool you into delivering bad care. There are plenty of data that actually show that DOACs are more effective for preventing stroke than warfarin amongst patients with hypertrophic cardiomyopathy, with much less risk in terms of gastrointestinal bleeding, other major bleeding, intracranial hemorrhage. So DOACs are really our first choice agent for preventing strokes in patients with hypertrophic cardiomyopathy, unless the cost is exorbitant and prohibitive for the patient. Okay, back to what we were talking about. We've also found that race makes a difference in outcomes for patients. So this is another look at the SHARE registry. And again, in this cohort, Black patients only made up 8%, and this is just the centers in the United States. So we excluded the European centers because demographic data just isn't as robust. And there were so few data on Asian and Hispanic and other ethnicities and races that we didn't even actually include them. There's not enough data to really be able to analyze. 92% of the participants in the SHARE registry are Caucasian. Now, we know in a disease that affects gender and race equally, that this really represents an underdiagnosis of hypertrophic cardiomyopathy amongst those who are Black. Other things to notice is that Black patients are actually diagnosed younger than white patients in this cohort. And when we do genetic testing, the percent who actually have disease-causing variants is lower, almost half of what we find amongst Caucasians. We also actually find that there's a little bit less uptake of genetic testing amongst Black patients as compared with white. The prevalence of hypertension is higher amongst Black patients with HCM than white, and the burden of congestive heart failure and symptoms related is higher amongst those patients as well. When we look at outcomes in terms of therapies that are provided, septal reduction therapy referrals are made far less frequently for patients who are Black than those who are white. And when we look at whether or not they're affected more by heart failure, we actually find that that is the case. It's not just the absolute numbers. When we take a look at everything else, heart failure seems to be much more predominant amongst Black patients than white. And even though they're diagnosed at a younger age, they're more affected and have a greater burden of symptoms and kind of later advanced stages of disease. So again, it's hard to believe that the race in and of itself has some interaction with the genetic variant. It's much more likely that diseases like hypertension that play a role in the stiffness, the thickness of the muscle, and the undertreatment of hypertension has a role to play with that, or that the referral patterns and the general undercare that Black patients may be getting leads to these kinds of more adverse outcomes in a Black population. So how can we prevent these complications from happening? Is there a way to target early disease initiating pathways? So these are two patients of mine. The one on the left carries a familial myosin binding protein C3 pathogenic variant. She has no hypertrophy, but she is quite hyperdynamic. This is her echo. And you can see how much of a super squeezer her left ventricle is. Is there a way for us to prevent this patient of mine to becoming this patient of mine who has significant hypertrophy, significant left atrial dilation? Well, we're working on it. So there's mouse models of sarcomere mutation, hypertrophic cardiomyopathy that have shown a role for TGF-beta in the pathogenesis, and such that the sarcomere mutation increases the sliding velocity, increases the contractility and force with which the motor is actually contracting. That increased force actually activates TGF-beta, which then creates this profibrotic cascade. Now we have non-myocyte proliferation, more and more thickening of the ventricle. And so what we're curious about is, if we were to block TGF-beta, can we prevent this cascade from occurring and prevent some of the downstream consequences of HCM? And it turns out you can actually block some of that TGF-beta cascade with inhibiting the angiotensin receptor. And so that's what led to the VANISH trial. So this is a phase 2 randomized controlled trial of valsartan for attenuating disease evolution in early sarcomeric hypertrophic cardiomyopathy. There were 2 cohorts of patients in this study, but I'm really only going to focus on the primary analysis cohort, which was patients who are genotype positive and have evidence of disease. There's about 150 patients that were targeted, ages 8 to 45, so earlier in the disease process. Maximal wall thickness ranging 12 to 25. Again, we don't want someone who has massive hypertrophy who's really kind of reached the kind of fully bloomed form of hypertrophic cardiomyopathy. What we're trying to prevent is that from happening. So if you're going to, have an intervention, you want to intervene in an earlier phase of the disease. We wanted these patients to not have a significant symptom burden and no outflow obstruction, because we didn't know how valsartan was going to affect outflow obstruction. At baseline, patients come in and undergo, a history, physical exam, a detailed family history. Everybody is genotyped, EKG, echo, biomarkers obtained, and then everyone underwent cardiac MRI and cardiopulmonary exercise testing. The active run-in phase consisted of up-titrating the dose of valsartan every 2 weeks to the maximal dose, 320 milligrams a day for adults, and then depending on the body weight of the child, either 160 milligrams a day if over 35 kilograms, or 80 milligrams a day under 35 kilograms. And at the end of that active run-in phase, if they tolerated both the placebo or if they tolerated the valsartan, then they would be randomized to either placebo or valsartan. They underwent evaluations a year later and 2 years later. And the evaluations really consisted of history, physical exam, EKG, echo, and biomarkers. At the 24-month time period, we did cardiac MRIs and cardiopulmonary exercise testing. Because we're talking about early phase disease and about a drug we don't really know how it's going to interact, we didn't think that looking for a large change in one particular marker of bad outcome was going to make sense. We're also talking about early disease. So picking one bad outcome and expecting to see that bad outcome occur in a matter of 2 years is pretty tough. So what we actually chose to do was to have a primary composite endpoint, really looking at parameters that focus on the structure, the function, and myocardial injury and strain. So it's a Z-score from change from baseline to year 2 of the body surface indexed left ventricular mass, left ventricular volume, end diastolic and end systolic volumes, maximal wall thickness, and then tissue Dopplers, as well as log transformed high sensitivity troponin and NT-proBNP. Here's some baseline characteristics. So I look at this table when I'm thinking about the patient that's sitting in front of me to determine, is my patient somebody that would have been considered for this trial? And so the mean age for patients was right about 23 years of age. Their blood pressures are low, normal, and they're largely asymptomatic. Maximal wall thickness was about 16, 17 millimeters. Their baseline values of the composite, kind of individual composite markers, variables that we were looking at. I just want to show you that the left atrial volume index is elevated. So 34 being the upper limit of normal. These patients already have some mild left atrial dilation, even though they're in the earlier phases of disease. And that wall thickness in the entire cohort was about 17 millimeters. So when we looked at the primary composite outcome at the end of 2 years, we found that those patients treated with valsartan had a significant improvement as compared with those treated with placebo. And these are the individual markers that made the biggest difference. So the red line is valsartan, the blue line is placebo. And this is left ventricular maximal wall thickness adjusted for BSA. And you can see that those who received valsartan basically stayed unchanged, while those who were on placebo had progression of wall thickness. The end diastolic volume in those patients that were treated with valsartan actually increased, improved, where it stayed the same on placebo. And then markers of diastolic dysfunction, so tissue Doppler adjusted for age, also improved, or stayed the same on valsartan and declined on placebo. When we look at markers of myocardial strain here, this is the NT-proBNP. You can see that with treatment with valsartan, we actually had stability over time versus those patients on placebo had increased myocardial strain. This is the first data of this kind that we have. This is the first drug that we have that's been shown to have any effect on disease progression. Risk assessment for sudden death has changed and updated in the last 10 years as well. So the traditional risk factors that we think of are maximal wall thickness 3 times what's normal, so 30 millimeters or more, a family history of early, under the age of 50, sudden death, cardiac arrest, sustained ventricular tachycardia, or death in a family member with HCM at sudden death at any age. Unexplained syncope in the previous 6 months. Not, I passed out when I was playing soccer when I was in high school and I'm 40 years old. Not, I was sitting drinking 7 beers at this music festival and it was 90 degrees and 90% humidity. It is, I was driving, I was minding my own business, and the next thing I know, I was in a tree. It makes a really big difference. We don't want this to be syncope that's preload dependent, and it's very hard to suss that out in some patients that have significant outflow obstruction. Newer risk factors that have been recognized are the apical aneurysm, and that's independent of size. So in cohorts of patients with apical aneurysms, as compared with all other HCM patients, the risk of malignant arrhythmic events is 5-fold that of other patients with HCM. So in our practice, an apical aneurysm is an automatic indicator for a defibrillator. Left ventricular systolic dysfunction is also now recognized as being a marker for advanced disease. And systolic dysfunction in a patient with hypertrophic cardiomyopathy is not an ejection fraction of 35%. My antennas start to go up when my patient's ejection fraction is 55%. So an EF of 50% is when I start to get real aggressive about Entresto, SGLT2 inhibitors, and all of the kind of the drugs that we use for GDMT. There's also incremental risk factors, and non-sustained ventricular tachycardia is one of them. So this is a risk factor that has actually been downgraded in terms of its risk. When you look at patients, all comers with hypertrophic cardiomyopathy, non-sustained VT is actually very common. Why? Because we define it as 3 beats over 120 beats a minute. I think I just had one myself. So we can't just use that as a marker to implant ICDs. We have in the past, and when you look at registries of ICDs in patients with HCM, you actually see that only about a quarter of those patients that we have deemed as being high risk ever get an appropriate therapy. So we have very sensitive kind of antennas about risk factor identification, but we're probably not doing right by our patients by implanting ICDs for every little run of NSVT. Extensive delayed enhancement on cardiac MRI, so involving more than 15% of the LV mass, has also been recognized as a risk factor. It correlates with arrhythmic events and appropriate ICD discharges. I use the European Society of Cardiology HCM risk calculator. It adds age weighting as a greater risk at younger age, as left atrial size, maximal wall thickness as a continual variable, as opposed to 30 millimeters were done and 28 millimeters were not. It adds outflow gradient to it, but it does not add genetics, delayed enhancement, EF, or aneurysm to the risk calculator. If you were to Google HCM ESC risk, this is what you'll come up with. This website's open in my clinic. Every single patient, I'm doing this calculation. So you plop in, all of these variables, and it will print up for you what the estimated risk is over the next 5 years. So for example, in a 20-year-old man with HCM who has reverse curve morphology, no obstruction, maximal wall thickness of 20 millimeters and a left atrial 2D size of 42 millimeters, his 5-year risk is 3.2%. If we add non-sustained ventricular tachycardia, that 5-year risk becomes 7% and is significant. So I actually, when I'm seeing somebody, I don't just put in what their numbers are now. I play with it to see, okay, I haven't found non-sustained VT in you, a good run, 10, 15 beat run. But if I do, what would your risk be? And that helps me figure out, okay, do I need to monitor you more carefully? Do we need to image you? Do we need to consider repeating a cardiac MRI? If you've never had one, would I do a cardiac MRI to figure out, do you have additional risk that doesn't go into this calculator? The strategy here would be yearly follow-up, extended event monitoring, yearly cardiac MRI to look for evidence of delayed enhancement, and then really advising about warning symptoms. That patient is really different than the 70-year-old person with hypertrophic cardiomyopathy who has a 17 millimeter sigmoidal septal hypertrophy, significant outflow obstruction, same degree of wall thickness, a left atrium that may actually be a little bit bigger than my 20-year-old guy. That guy's 5-year risk is 1.6%. If I found non-sustained VT, his risk would be 3.5%. Why? He's 70. He's already won the game. So what's the strategy here? I actually won't do event monitoring in my patients who are over the age of 70. It won't make any difference, and it just adds to the anxiety level. We still do yearly follow-up. I would only do monitoring if patients have symptoms, and really then what I'm looking for is AFib, not so much the non-sustained VT. I would only obtain a cardiac MRI if I'm really thinking about doing septal reduction therapy, but I'm not looking for markers of risk. All right, so now we're going to talk about management of obstructive hypertrophic cardiomyopathy. There's been a lot of movement here, and we have a lot of data to get through. The standard care of HCM in terms of pharmacotherapies has been that if you're asymptomatic, we may consider beta blockers or calcium channel blockers to try to suppress that outflow obstruction in order to try to prevent the left atrium from becoming bigger and bigger and prevent the kind of further thickening of that basal septum when it's seeing that kind of pressure overload. But in general, we may not even treat with any medications. If they become symptomatic, now for sure, we're going to be using non-vasodilating beta blockers, calcium channel blockers. Maybe we would go to disopyramide, diuretics if there's evidence of volume overload, and then septal reduction therapy if our medications aren't working. None of these medications were devised with hypertrophic cardiomyopathy in mind. They're devised for all kinds of other purposes, and we use these medications because we don't have another option. They don't get at the underlying pathophysiology. So from all of the genetics work that has been done in the last couple of decades, what we have learned is that the cardiac myosin binding protein C3 really acts like the molecular brake within the motor, and the myosin head, the MYH7, is the force producing head. So this is like a gas pedal and a brake pedal, and they need to be in a good relationship with each other in order for things to go normally. Pathogenic variants in either of these two genes cause too many cross bridges between the proteins, and that results in increased myocardial force generation and abnormal relaxation. So what we see on echo and cardiac MRI in terms of thickness, left atrial dilation, that's the end game. The first thing that happens is this increased contractility. What we now know is that the myosin heavy chain kind of looks like a Y, and it has these two heads that interact with the actin. And if there are too many interactions, we get this very vigorous hypercontractility, impaired or slowed relaxation, and that ends up ultimately leading to the morphology of HCM that we see. This is a graph that shows what the sarcomere shortening should be in a healthy individual, what it is in somebody with hypertrophic cardiomyopathy, and what it is if you treat somebody with hypertrophic cardiomyopathy with a myosin inhibitor, a molecule that can actually inhibit that force-producing myosin. That data led to the Explorer HCM study. So this is a phase 3 randomized controlled trial of mavacamten, the myosin inhibitor, versus placebo. We devised a 6-month drug trial and then a 2-month period at the end where the investigational drug was taken away and then assessments done again. At baseline, echoes, cardiac MRIs, CPETs are done. Echoes are performed pretty much every month with an opportunity to increase dose at 8 weeks and at 14 weeks. End of treatment was at 30 weeks, and then end of study was at 38 weeks. Patients had to have a gradient, a left ventricular outflow gradient of at least 50 millimeters of mercury at rest with Valsalva or post-exercise, one of those, in order to participate. They had to have normal ejection fractions. Why? Because this is a myosin inhibitor. It is going to reduce the contractile force of the heart. They had to have symptoms and in order to be able to participate. So cardiac MRIs were done at the beginning and at the end of treatment, and Kansas City cardiomyopathy questionnaires were done at regular intervals throughout. The primary composite was a functional endpoint, and this is a different. So it consisted of either a greater than or equal to 1.5 mil per kg per minute improvement in peak VO2 and a reduction of symptom burden, reduction of New York Heart Association class by at least one class, or a more significant improvement in cardiorespiratory fitness, at least 3 mil per kg per minute, and no worsening in terms of symptoms. Secondary endpoints included the gradients, outflow gradients, the peak VO2 itself, the proportion of patients that had improvement of at least one New York Heart Association class, and then the KCCQ and HCM symptom questionnaire, shortness of breath subscores. And in terms of the primary endpoint, what we found was that those patients that were treated with mavacamten had a significant improvement in their cardiorespiratory fitness and symptom burden as compared with placebo. We see that both in terms of kind of a smaller improvement, better in terms of functional capacity, more symptom relief, and in terms of greater cardiorespiratory fitness improvements with stabilization of symptoms. When we look at the gradients, here you're looking at post-exercise gradients. So we only did exercise testing at the beginning and at the end. So that's why you only see 2 data points. You see how significant the obstruction was. So post-exercise gradients of about 80 millimeters of mercury at rest, or sorry, at baseline. And after 30 weeks of treatment with mavacamten in the blue line, you can see that the post-exercise gradients dropped down to 38 millimeters of mercury versus those patients that were treated with placebo basically had no change. I like to point out that the kind of threshold for where we send patients to the operating room or to the cath lab for septal reduction therapy is 50 millimeters of mercury. Valsalva gradients came down significantly after about a month of treatment and stayed low the rest of the 6 months. Resting gradients came down. It took a little bit longer for those to really stay down, but they come down and they stay down. And then what everybody's kind of interested in is the ejection fraction, again, being a myosin inhibitor. So in the beginning, the patients are very hypercontractile. Mean ejection fraction amongst all of them is about 74%. And you can see that there is a small decline in the ejection fraction by about 5%. It is a statistically significant decline, but it stays within normal limits. NT-proBNP and high sensitivity troponin come down pretty dramatically with treatment with mavacamten. It's interesting to think about what this is doing in terms of myocardial strain. The cardiac MRI sub-study, unfortunately, only enrolled about 37 patients. So we don't have a lot of data, 17 on mavacamten, 18 on placebo. But you can see that the primary endpoint of that sub-study, being the left ventricular mass index, actually had a significant decline in patients on mavacamten treatment as opposed to placebo. There was also a decline in other measures of hypertrophy, so maximal wall thickness, the maximal septal thickness, global LV mass, all of those came down with treatment with mavacamten with just 6 months. Ejection fraction as measured by cardiac MRI was down about 6%. And then what I'd like to also point out is that there was no change in fibrosis burden amongst these patients. Now, this is only, 17 patients treated for 6 months. So there's that caveat. Also interesting is that the left atrial volume index came down with just 6 months of treatment. This is a sample patient that participated in the trial. You can see what the burden of hypertrophy was at baseline. And then after 6 months of treatment with mavacamten, and the same with the 4-chamber, you can see that the thickness actually reduces. On echo, we actually saw a lot of the same things that I've already shown you. And because it's a larger cohort, not just 17 patients in the cardiac MRI sub-study, you can actually see that there is a significant decline in the left atrial volume index, and that actually correlates with the improvement in NT-proBNP. The same thing with the tissue Doppler. So markers of diastolic function improve with treatment with mavacamten, and we can see that correlates with changes in BNP. This is a sample patient echo treated with mavacamten. So this is their echo at screening. So what you see is that the resting gradient is 136 millimeters of mercury with Valsalva 144 and relatively low tissue Dopplers. At 6 months of treatment with mavacamten, the resting gradient is 6, Valsalva 17, and that there is a slight improvement in the diastolic function. So there's a KCCQ overall summary score sub-study that was done as well. So the KCCQ is a 23-item cardiomyopathy specific questionnaire. The range is 0 to 100, and higher scores are better, indicating fewer symptoms. We're cardiologists. high numbers are good. We're overachievers. Minimum clinically important difference from baseline is considered 5 points. So 5-point change represents a small change, 10 points a moderate to large change, and 20-point changes are considered large to very, very large changes. The overall summary score comprises all of the domains: symptoms, physical functioning, social functioning, and quality of life, where the clinical summary score really gets at symptoms and physical functioning. And what we see here in the overall summary score is that those patients treated with mavacamten in the blue have an improvement in their KCCQ, their patient's own assessment of their health status. But at week 30, we take drug away, and then we come back 2 months later and look at what happens to their sense of health status. It dramatically plummets. When we look at the proportion of patients who either experienced a deterioration or no change with the study drug, those patients who received placebo fared worse than those who actually got mavacamten. Very large improvements were seen in 36% of the patients that received mavacamten as opposed to 15%. And that means that it correlates to a number needed to treat of 5. So for every 5 patients treated with mavacamten, you're going to see 1 who actually has a very large improvement in their health status. To see no change and no deterioration, really, you'd need to treat about 7. Safety data. So there was a 97% completion rate through 30 weeks of treatment. 3 patients discontinued, 2 on mavacamten, 1 on placebo. Nobody withdrew due to reduced ejection fraction or symptoms of heart failure. 6 out of 7 patients that were found to have reduced ejection fraction with an EF ranging 35 to 49% on mavacamten had a complete recovery back to baseline with taking the mavacamten away. There's a long-term open label study of Explorer, and patients were given that opportunity so that even if they were getting placebo to begin with, they had an opportunity to actually be on mavacamten. And this is an ongoing 5-year study. We have data through week 84 cut. And the interesting thing about this data is that dose adjustments here are all made based on site-read echo measurements of Valsalva gradients and ejection fraction, as opposed to the original Explorer study, where everything was done based on PK and centrally read ejection fractions and outflow obstruction. Temporary discontinuation criteria included an EF less than 50%, a very high plasma trough concentration, or prolonged QT. And what you can see is through week 84, we continue to see a significant improvement in resting outflow obstruction and Valsalva outflow obstruction in those that are treated. The resting ejection fraction does decline. And this is the red line is the central read, and the green line is the site read. So it's actually interesting to me that the site read echoes, give a more conservative ejection fraction than the central read ones. But we don't see a dramatic decline in the ejection fraction. It goes from about 74% down to about 66%. NT-proBNP, just like what we saw in the parent study, declines pretty significantly within the first month of treatment and stays down. And New York Heart Association class improves significantly and stays, improved through a week 48 data cut. So there were 10 patients who had mavacamten concentrations greater than 1,000 nanograms per mil that led to a temporary discontinuation, 7 who had increased QTC, and 12 who had an ejection fraction less than 50%. Of the 12 who had an EF less than 50%, only 2 correlated with a very high plasma concentration. 6 of them had intercurrent illness, so AFib, for 5 of them, and with RVR and kind of a decline in their clinical status, and 1 who had hypertensive emergency. 5 permanently discontinued from the drug, but then 1 actually re-enrolled later. So the rate of kind of low ejection fractions in the long-term extension study is about the same as in the parent study, about 5%. There is a new kid on the block, aficamten, and the difference between aficamten and mavacamten is an optimized half-life. So mavacamten has a half-life about 9 to 11 days, where aficamten is about 3 to 4 days. The advantage of that is that it's on easy and it's off easier. If you need to pull it away, you'll see the results faster. It has a shallow exposure response relationship and minimal drug-drug interactions, none of the significant CYP inhibition or inductions that we see with mavacamten. There's a phase 2 study of aficamten called Redwood HCM that was looking at placebo with standard of care and aficamten with standard of care over a 10-week period of time. Each of the dose titrations occurred every 2 weeks as opposed to every month with mavacamten trial. And all of the dose adjustments were based on echoes that were site-read, none that were centrally read, and no pharmacokinetics played a role in the titrations. Again, to participate in this study, patients had to have significant outflow obstruction, significant symptoms, and normal ejection fractions. And what we see is really the same. So here, the gray line is placebo, the blue line is a lower dose of aficamten, and the green line is a higher dose of aficamten. And what you can see is that with either low or high dose of aficamten, within 2 weeks of treatment, we see a decline towards normal of the resting outflow obstruction, the same with Valsalva. We don't see the effect of the higher dose as much in the resting gradients as we do in the Valsalva gradients, where higher doses are more effective at keeping those gradients down. And there is, compared with placebo, a decline in the ejection fraction, but you'll notice this is an EF of 60%, this is an EF of 70%, and they live right in the middle, which is normal. There's a significant improvement in New York Heart Association class in patients with aficamten. This is placebo, lower dose aficamten, higher dose aficamten, and you can see that more patients had at least a 1 New York Heart Association class improvement on a higher dose of aficamten than lower, and as compared with 10 weeks of placebo. The biomarker evaluation in this 10-week study is a little less impressive than a 6-month study of mavacamten, but we do see that there is a significant improvement in NT-proBNP compared to baseline with 10 weeks of treatment, but not a significant decline in high sensitivity troponin, though a trend. Safety data, there were 2 serious adverse events that were reported in cohort 1 and none in cohort 2, cohort 2 being the higher dose of aficamten. And there was 1 instance of stress cardiomyopathy, but it was in a patient that was on placebo. And the other major adverse event was a back pain that took a patient to the emergency room. And so because it's an ER event, it counts as a serious adverse event. There are no treatment-related serious adverse events. No patients met the stopping criteria of an EF of less than 40%. 2 did have an ejection fraction of less than 50%. 1 that recovered with a protocol-based dose reduction, and the other who actually had atrial fibrillation. And once the AFib was treated, the EF came back. 1 small little plug. I didn't include a lot of exercise data. You know, it's my thing, but I just wanted to tell you that the work that we've done finally changed the guidelines. So the last iteration of the hypertrophic cardiomyopathy guidelines that was published in 2020 actually has a class 1 indication for mild to moderate intensity habitual recreational exercise, and it's been shown to be beneficial. The high intensity interval training study that's being done at UT Southwestern, we will have data from in the coming months, and that's also looking favorable. So in conclusion, the risk of congestive heart failure, atrial fibrillation, and stroke is much higher than the risk of sudden death, with disparate risks based on sex and race. We need to pay attention. Administrating ARBs early in the course of the disease could attenuate progression of hypertrophic cardiomyopathy. Sudden death risk assessments now include new markers left ventricular aneurysm, ejection fraction, and downgrades the importance of non-sustained ventricular tachycardia. And standard of care therapies don't address the underlying pathophysiology, but the new treatments that are coming around the bend do. I'd like to thank our team. Unfortunately, Barb, who is like the absolute pillar of our team, I don't have a picture of that I can share. So that's Barb's name there, but this is our whole team. Thank you all so much.
Thank you, Sarah. That was a phenomenal talk. I have a few questions from the virtual audience. So I'll start with that, and then I'll
Okay.
open to the physical audience. So Dr. Eagle was asking, do insurance companies have a cutoff of 5-year risk for ICD implantation?
No, I don't think that insurance companies have really gotten wise to that yet. I've not seen that happen, not in HCM, not the way that, you know, an ejection fraction, they'll decline if ejection fraction in a patient with DCM isn't within their cutoffs. We have not seen that.
Dr. Aronson was asking about the baseline characteristics of the Danish trial, and if there was any significant difference at the baseline that could have explained the difference in outcomes.
There was a little bit more hypertrophy burden in the patients on placebo than on valsartan. So certainly that could play a role. It wasn't a significant difference, but that despite the randomization and kind of stratification, that did occur. Yeah.
Dr. Thompson was asking about the imaging guided dose titration, you know, that's happening now. Do you foresee that that will continue to happen in the future when these medications are widely available? Is this something that is clinically needed, or it's just being done because of early phases of treatment?
Yeah, so while the data is awesome to talk about and is really exciting, the reality of mavacamten is actually royally painful. So mavacamten, based on the Explorer randomized clinical trial, was approved by the FDA for commercial use in February, and they implemented a REMS system. So this is not something that we in cardiology are particularly familiar with. It's something that oncologists are more familiar with. So this is a risk mitigation strategy. So not everybody can prescribe mavacamten. You have to register with the FDA to be able to prescribe it. Not every pharmacy can dispense it. There's actually only 10 in the United States that can dispense it. They also have to register with the FDA. And the patient who's going to be treated with mavacamten also has to register in the REMS. We can dispense medication at 5 milligrams a day. We have to perform echocardiograms 1 month, 2 months, and 3 months after initiating the medication. You can't dose up titrate in that time. You can only down titrate or maintain dose dependent on the ejection fraction and the outflow obstruction. If everything's going okay at 3 months and the patient still has a hyperdynamic EF and significant outflow obstruction, that's your first opportunity to increase dose from 5 to 10. Then you have to bring them back again a month later and repeat the echo. And then you have to do it every 3 months when you're on a stable dose. So when you think about the cost of the medication, which is $90,000 a year without insurance kicking in, and the cost of the echoes, it's not small. Bristol Myers Squibb understands what's happening in the world, and they know aficamten is very close behind in development, and they are very interested in getting this drug into the hands of patients. So they've been very generous in pushing, in making contracts with the big insurance companies. So there's actually very few that won't cover it. And for those that don't, there's a $10 a month copay program that BMS participates in. If the cost of even the copay from the insurance is too high, we can actually apply for a grant from BMS, and the drug is completely free. In order to cover the cost of echoes, though, we actually have to apply for grants from foundations. So Barb, who is, like I said, the pillar of our program, has been trying to manage all of this for our now 30 patients. That's all we have on the drug is 30, and we are pretty much coming out of our skin. So yes, the imaging and the reliance on imaging is here to stay. And it's very unlikely that the FDA is going to change their recommendations in terms of imaging until the Explorer LTE, the 5-year data is out, and probably not even until the Discover HCM, which is a registry of kind of real world obstructive HCM and mavacamten use, until that data is available.
In pulmonary hypertension, we're also very familiar with the REMS.
Oh, of course you are. Yes, of course. So I just want to say one thing that I forgot to say, and I didn't realize it until just now, actually. Every piece of data I showed you, I feel really biased, and I probably should have put this in my disclosures. Our group has participated in every single one of the pieces of data that I showed you. There's not a lot of places around the country that can say that they have that much of an active role in the progress of understanding and treatment of a disease process. I'm super proud of our program. That's it. Okay, sorry.
Dr. Pinsky had a question.
I was going to do a super proud comment too. I mean, the fact that the work you and your colleagues have done have changed the guideline in practice, that's like a holy grail for many of us. I mean, that's a wonderful career accomplishment. I love the fact you showed that. So congratulations for everything. I have a question. Are there off-target effects, for instance, that one complication, which was maybe musculoskeletal, maybe it was nothing, does it make people weak or have other muscular effects? And then as another question, would there ever be an indication for LVH due to hypertension or other forms?
So I'll address your second question first. So acquired LVH and outflow obstruction related to that is much more common due to hypertensive heart disease, chronic kidney disease, diabetes, obesity, untreated sleep apnea, all these other comorbidities that actually create the same pathophysiology in the heart in terms of hypercontractility and outflow obstruction. And that group of potential patients far exceeds the number of patients with HCM. There is an ongoing study of mavacamten versus placebo in this type of patient population, kind of a HFpEF patient population. And I'm sure there is a lot of interest about that. There's interest even in using mavacamten post-MI treatment. There's all kinds of things that they're kind of fiddling with that I won't go into. And then in terms of the off-target effects, so it is very specific cardiac myosin inhibitor. Anecdotally, we had 2 of our 11 participants in the Explorer study that felt that there was a significant kind of muscle weakness that they suffered. We actually pulled them off drug and then put them back on and saw that correlation. The pharmacokinetics division of, at that point, myocardia swore up and down, left and right to me that that was just kind of incidental. So that musculoskeletal, that was our patient. And I think, you know, as we've gone on, we had 1 patient in Valor out of 8 that also notices muscle weakness. We have 1 participant in a long-term open label study of Redwood, so aficamten, that also says that they notice it. So I think it kind of remains to be seen, you know, once it has greater uptake, whether or not we see a bigger influence there or not. Mm-hmm.
Right. Thank you so much, Dr. Saberi. That was a great talk.
Yeah, you're
Thank you, everybody.
welcome. Thank you so much for having me. This was awesome.